Today we're joined by Dr. Z. He's a spine surgery fellow and a fellow neurosurgeon who educates and shares knowledge and behind the scenes looks on social media. And we're super excited to have you here today. Thank you for taking time out of your busy schedule to talk with us. And love to just start by kind of you sharing your story a little bit, how you got started on social media, and take it from there.
Awesome. That sounds great. First off, thanks for having me. And this is such a pleasure, such an honor. Dr. Hefflinger and you guys have been such an instrumental part of why I started all this stuff. So you guys are phenomenal,
Wow.
and you guys are essentially one of the reasons why I wanted to do this. So thank you both for having me.
Wow, it's
Um,
humbling us.
so you guys are the pioneers. You guys are the OGs.
Yeah.
So yes, I am a spine fellow. I finished my residency last year, about 6 months ago. I completed my residency, and so now I'm finishing up complex spine fellowship. I have two fellowships. I did one in deformity surgery, and then now I'm doing a second one in minimally invasive spine surgery. And I started this social media thing probably just over a year now, and I'd say
Hmm.
like a year and 3 months. It's been about 15 months, and I started it as a way to kind of be able to share the knowledge that I had and that all neurosurgeons had with the general public in a situation where you might not have enough time to tell a person their disease pathology. So for example, if somebody comes in with a disc herniation, one of the more common things that we see in neurosurgery, a lot of times a neurosurgeon would like to sit down in the office and kind of pull up the images and show them and say, this is what's going on. This is what's impacted. Here's why your nerve root is compressed and all that stuff. And this is the surgery we're going to do. Unfortunately, in reality, that time, a lot of doctors don't have that luxury. So
Yeah.
kind of what I did was I wanted to have a platform where I could explain to people that didn't necessarily get the interaction that they hoped for with their physician. And I could speak kind of to that and tell them, hey, this is what a disc herniation is, and this is the surgery that your doctor might recommend for this, and kind of explain to it. So that's kind of why I started it. That's what I do, and it's been such a phenomenal journey so far. It's been very well received. I've been very fortunate, and I'm excited to kind of keep doing stuff like that.
No, we love your content. It's awesome. And we
Oh
really
man.
like how you're integrating AI nowadays, which is something that we're a little behind on, but your videos are awesome.
No, but again, we were talking about this briefly, but Kevin was asking me this. I think the original content, the real content, the stuff that you post, just holding up your phone, is what really connects with audiences the most. And I am a big fan of AI stuff, but a lot of it is really just trying to connect with an audience on a
Yeah.
human level and just speaking to them face to face, and through a camera, of course. But that's
Yeah.
kind of what I'm trying to get at, is that content is very valuable.
Yeah.
Yeah, we tried to a lot of times with our different stuff too. Some of the medical trivia. It's kind of funny. People like the raw and authentic stuff, not super overly like edited and polished, but just kind of like raw,
Yeah.
just the first take. That's why it's funny.
Hmm.
Sometimes you'll put so much effort into a piece of content, it doesn't do as well, and you spent so much time on it. And then
I
the ones
know.
that you just did in one take that didn't take very long will take off. So it's
Yeah,
interesting.
like it can be frustrating. I've made videos where it has all the bells and whistles, the editing and all that stuff, and
Yeah.
it'll get
Yeah.
whatever 5,000 views or something like that, where I'm like really putting in a lot of effort. I do a lot of research, but then there will be a time where I'll take out my phone and say, it's 3 o'clock in the morning. I just finished surgery, and I'm really grateful to be here.
Yeah.
That video will get like 4 million views, and I'm like, this is crazy. So
Yeah.
it just changes, I guess. The way that you interact with the audience, I think, is very
Yeah.
important. And
Well, and I
yeah.
think that's why you have to remember why you're even on it. Because I mean, we've had those periods now where you don't get hardly any views, and even though we have a pretty big following, it becomes disheartening. But then you have to remember, like Kevin always tells me, you know, like we think 10,000 views isn't a lot, but Kevin said, what if you're standing in a stadium full of 10,000 people? Would you consider a lot of people watching you? And if you look at it that way, I mean, it really, you're reaching a lot of people, even with videos that you consider are not getting a lot of views. And you just have to go back to why you're even doing this for people. Why are you on it, just to get views, or are you out there really trying to educate one person or get through to somebody? And I mean, you almost have to step back, I think, and think of it that way. And he reminds me
Yeah.
constantly about that, which is good advice.
Well, I think it's
Yeah.
kind of like a
I
lot
agree.
of things. It's the hedonic treadmill of you get and just as humans, you get used to a baseline of something, whether that be like views on social media or money or lifestyle, and then it's hard to when it drops back down. But you can only control. I mean, I'm a big believer in stoicism. You can only control your inputs. You can only control how you react to what happens to you. You can't control if you put in the most effort ever and a video doesn't do well. I mean, who cares? You just got to make another one and try out different stuff. So,
Yeah,
but I think it's
definitely.
very important there's people sharing, there's going to be constantly people putting out other types of stuff who aren't experts. So you might as well have all the experts on social media sharing good knowledge where they're researching stuff like you and my dad. I think that's very important. Some people will be like, why are these medical influencers out there? I think if we're going to have all the other people sharing knowledge, why aren't the people who are actually experts in different fields sharing knowledge too?
And I also think, part of this whole mystique is people don't get a chance to meet neurosurgeons. And so that's been part of it for me, for you, because people don't get a chance to see us very often. So just like me, I'm 60 years old. I did residency over 30 years ago. You just finished your residency. Now you're in fellowship, but I'm sure things have changed a lot. Like, how was your residency for you? People are fascinated to hear how residency was. And I've talked about mine in the past, but I'd be interested to hear what residency is like nowadays. What do you think are the highlights of it, the downsides of it? How busy is it? Do you have any free time?
Yeah.
Stuff like that.
So I feel like I can talk about this for hours, but I will start off by saying that I will say that my residency, I feel like to me was very, very challenging, but there's an asterisk here in that it pales in comparison to what individuals have had to do in the past. So again, I've said this before and I'm going to say it again. I think your residency was more challenging than mine because the laws and all the regulations were not in place back then. And so a lot of people don't know is that residents have an 80-hour work time restriction. But this 80 hours is a relatively new thing. It's only been around, honestly, I couldn't even tell you. I think it's been around for like 15 years, maybe, I don't know, 20 years?
It was like,
15 years, I think.
1998. I think it was 98. It went into effect like the last
Oh,
year of my
wow.
residency.
Way more than that.
Or maybe
Okay. So
somewhere
yeah,
around.
I was way off. But yeah, so I guess it's been around for a little while. So, I mean, this 80-hour work restriction thing has some people saying that it was a good thing, and then other people saying that it takes away from the training that you need. So some of the originals are saying, you don't understand what it's like to work 144 hours a week. So Dr. Hefflinger, I think one of your videos, you said you worked, what was the longest run that you had per week?
Well, I actually backed the hours off a little bit because I had 7 hours off that week, and that was time to sleep. So I actually slept for 7 hours in a week, and you can take that for a grain of salt.
Wow.
But that's actually what happened. And those days, that was just an insane time, and it was just every other night call, and we were up all night. The nights we were on call, we were up all night, and the nights we weren't on call, we had to be in at like 3 o'clock to pre-round for the residents, and then we would stay till like 11 or midnight at night. So you get another 2 hours sleep. So every other night I got 2 hours sleep for.
Well, and the caveat there, like you do, like you've said in our videos since, is that you weren't the attending. You weren't the one making people all like, were you making the life and death decisions? That wasn't you at the point in time.
No, we were
exactly.
workhorses.
Exactly,
we were working, doing stuff that needed to be done, just small stuff on the floors and stuff. But you're still up, and it's sleep deprivation is not a good thing at that extreme, obviously.
No, I agree completely. So my longest I guess work week was 112 hours, I believe, but that's off the record. My residency program did not know about it. So, that was just one of those things because they were very strict with their 80-hour work week thing. But, there was times where I felt like I wanted to stay there and contribute more or stay around and see more cases. So the way that I kind of went through residency was I was so afraid of being a mediocre surgeon when I was a resident. I wanted to be the best possible surgeon that I could physically be. And I thought that the only way that I could do that was by going to the operating room as much as possible. So my chairman, who's a very well-respected, very well-known neurosurgeon in the field, I was very privileged to work under him. He always said that it requires 10,000 hours to master something. And so my goal was to try to get 10,000 hours of every surgical procedure that I could so that I could master it. And so I would go to, no matter how big or how small the case was, I would always try to be there from start to finish. And I was very proud of myself for that. You can talk to any of the residents I've worked with. I was always one of the first people there, one of the last people there. And I was very proud of my work ethic because I was so nervous that I was going to be alone as an attending and not know what to do. So that's kind of how I approached my residency. And it was...
I hate to break it to you, but when that first day hits, it's going to be nerve-wracking. The first
I
day when you're in
believe
the
it.
operating room, the first day when you're in the operating room by yourself and there's no attending there, just wait.
Oh, Oh, trust me, I have no doubts. I have no doubts. Because now it's always easy to think to myself, like if I'm doing a case or whatever, even if, the attending steps out, they come
Yeah.
back. It's always easy for me to think to
Right.
myself, like if I need a backup, it's always there.
Yeah.
But you're absolutely right. Once you're the attending, and if, you need backup, you are the backup. So you have
Yeah.
to be the one to kind of figure it out on your own.
Yeah.
So, I mean, I'm excited, but also, cautiously optimistic about that, taking that step. But the training that I went through to, briefly answer that question was incredibly rigorous to me. It was one of those times where I would work 28 hours in a row, but then I would need to go home and then I would need to stay awake so that I could study for my
Yeah.
written exams coming up. So
Mm-hmm.
that was the hardest part of my residency was third year and fourth year, where I was studying for my written boards. I would work 28 hours and then I'd get a post call day when I was off. But what I did when I was post call is I would come home, and asterisk here, I do not recommend this. This was not a healthy thing, but I would drink about 2 or 3 Red Bull energy drinks. And then I would sleep right after that because then afterwards I know my body would wake me up. So I'd wake up after 45 minutes of a nap
Yeah.
because I was wired on caffeine. And then I'd wake up and I'd sit down at my desk and I would study for about 8 hours. So I did that for about 3 or 4 times a week
Wow.
where I would stay awake 28 hours, then I'd study for 8 to 10 hours nonstop, just wired on energy drinks. And it's because, again, it all boils down to the fact that I was so nervous about being mediocre. I did not want to be average. I wanted to provide, I took the responsibility so seriously that I wanted to be the best possible surgeon. And so I wanted to learn everything. And so I had all the books, all that stuff. And then I would sleep for a few hours and then I'd wake up at 3 a.m., just kind of like what Dr. Hefflinger did, wake up at 3 a.m., go work out, go do rounds, call the attendings, stay in the operating room all day, all night, go home, repeat, take another call day, have a post call day, same thing.
Yeah.
So I did that nonstop for several years. And I'm sure what you went through was very, very, very rigorous. But to me, that was very challenging.
Yeah, and it's hard to describe. People say, well, "How can you do that? It's not safe." And I think there's a component of adrenaline that when you're up like that, you just have adrenaline. Like you feel wide awake. I mean, I always felt fine. Yeah, you're a little bit tired, but it didn't feel like I was, out of it or anything like that. I
100%.
still got my work done, did everything that needed to be done. People, so I don't know. It's like when you
It's
have to do it, you do it.
I was gonna say it's game time. Like once you show up and
Yeah,
you're in the middle of the operating room, and then it's a trauma case. A
yeah,
patient needs a hemicrania or just needs something like a lami for cauda equina, whatever it is. You are so honed in that you don't realize that you've been awake for 28 hours. You are
yeah.
ready to operate as if you've been sleeping for the past 8 to 10 hours. You're
Well,
focused.
you train your mind to be focused. I mean,
Yeah.
it's a learning process, and it's just the way you
Hmm.
become.
Well, I think
Yeah.
you have to be very dedicated to it. It's like you say that it's why if you're going into medicine, especially something like neurosurgery that's so rigorous, is you have to have a strong why. Or some people, if they're doing it for kind of external rewards, then you're going to potentially burn out much faster than someone who has kind of is thinking about the intrinsic rewards of trying to help people and why they're doing it,
Yeah.
which is very important.
That's why a lot of times when people say like, what is the salary of a neurosurgeon or whatever, I get that a lot. Like when I post those videos that I was telling you about where I say, oh, it's 3 a.m., I'm going home or whatever. One of the more popular comments is, well, that's why they pay you $600,000, $700,000 a year. And I'm like, you don't understand. I'm a fellow. I get paid like 80, like 70, 80 grand a year before taxes. So it's not like I'm getting any of that. So there is no monetary income during my stage of training, and it takes decades before you can get to the point where you are financially secure. People have student loans they have to pay. People, you got to pay your malpractice insurance. You got to put a down payment on a house and all that stuff. There's so many factors that come into this that people don't really understand, that you're not going to be financially secure until late 30s, early 40s. So you are sacrificing
Yeah.
your youth and not really getting a real paycheck until way later.
Well,
Yeah.
I have friends right now that are just finishing up medical school. I'm 27 and applying in residency right now. They're third and fourth year medical school, and all the things you miss out on too when friends are doing stuff and you're just focused on school and
Yeah.
everything else. And then obviously when people are older, once you're mid 30s, late in 40s and stuff, then they can say like, oh, like you have it so well. But there's so much sacrifice that has to be made. And there, if you want to just get rich, there's definitely other fields that you can go into.
Yeah,
Well, I'd be interested
absolutely.
to hear, Dr. Z, what drew you to neurosurgery? Like, how did you end up
Yeah.
becoming a neurosurgeon?
That's a great question. I have different reasons, but I would say the primary reason is because when I was a second year resident, I'm sorry, second year medical student, I had a attending that came to our class. Every month we would have a different specialty that would come in and they would say why their specialty is so great. We'd have a nephrologist, a cardiologist, an orthopedic surgeon. All these people would just come and basically talk about their specialty.
Hmm.
The one person that came and stood in on that stage, there was one guy that came. He was a neurosurgeon, and he stood in front of the audience and basically said, "I don't think any of you should do neurosurgery."
Wow.
It's like he's like, "I recommend against it." He's like, "I did neurosurgery because I thought that it was really cool. Whatever, did all this stuff." He goes, "But." He's like, I'm not going to sit here and try to sell neurosurgery to you. He's like, it's a 7-year residency. It's really challenging. You're not going to get to spend time with your family. It's really tough, blah, 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 all this stuff. He didn't sugarcoat it. And when he got off stage, everybody was like, wow, that was weird. And so nobody
Yeah.
wanted to do neurosurgery. I am the type of person where if someone is like going to tell me, hey, this is too hard, like I don't recommend it, I'm the kind of guy that's like, wait, why can't I do that? I'm going to do that. So I was the only one in my class that applied to neurosurgery. And I think
Wow.
it had something to do with that individual because there were people that wanted to do neurosurgery. And then after that speech, nobody wanted to do it. And so I was the guy that was like, okay, now I never wanted to do neurosurgery in the beginning. I was going to do CT surgery. And then after that talk, I was like, okay, this guy says I can't do it. I'm going to do it.
Yeah.
So then I ended up emailing him one day and I told him, I said, hey, my dad actually had like a radiculopathy, had a problem with his lower back and he was having some issues with his leg. And he asked me, he's like, hey, do you know any neurosurgeons that could look into this for me? And I said, of course I do. So then I emailed him. He didn't know who I was. Emailed him. I said, hey, you came and you talked to my medical school class. My dad has this problem. He lives overseas. I was hoping I could show you the imaging. And he was such an incredibly kind individual. And he said, absolutely. And then he brought me into his office, put the CD in, took time out of his day, walked through the images with me, taught me, quizzed me on some anatomy, which I'll never forget, asked me about the psoas and all that stuff. And he really did a very good job in teaching and also showed me that my dad did have a disc herniation and said, I think your dad would benefit from a microdiscectomy. And I said, okay. So then I called my dad. I said, Dad, I found a neurosurgeon who's willing to help. We flew him in. He came in from overseas. We went to go see this guy. My dad was wheeled in to the hospital on a wheelchair to get his microdisc because he could not stand from the pain. He just couldn't do it. He was wheeled in, and then 45-minute procedure. I went to go see my dad. My dad walked out of that hospital after 5 or 6 hours. Walked out, and seeing that blew me away. I was like, okay, now I know for sure that, just a 45-minute procedure will change somebody's life, the course of their entire life. So that event was really the turning point where I said, okay, I think, it's a challenging field. It's really rigorous. It's demanding, and it requires a lot out of you. I am going to be the type of person that wants to see these results in my patients as well. So I committed myself at that moment, shadowed him, and he and I are still in touch. And he was really the reason why I decided to do this.
Yeah.
That's awesome.
Yeah.
And people may not realize, like in my medical school class, it was me. I think there might have been one other person that was going to go in neurosurgery and did not, but I don't know how many people. Were there 100 in my class? I don't remember, but it's not. There's usually 1 or 2 people out each class that go in the neurosurgery. It's not many people.
Yeah,
It is very few
per medical school class. Yeah.
In that at University of Rochester, there was only 1 resident per year. Now there's 2. But when you did, Dr. Z, when you did residency, was it 1 or 2 people a year, or I don't know, is it something else?
Yeah, we did alternating 1-2. So we were in the part of so we had 1 year where it was 1, the following year was 2, then we went back to 1, then we went to 2. So residencies in neurosurgery, it's if you want to apply for a second position, for an additional residency position, you have to trial it first. So then you get approved for all 1s, and then you get approved for 1-2, 1-2, 1-2. Then you get approved for all 2s. Then you get approved for 2-3, 2-3, 2-3. Then you get approved for all 3. That's how they do it. So we were 1-2, 1-2, and when I left, it was all 2s.
Yeah.
Got it.
And you were 7 years, right?
I was 7 years, yes.
Yeah.
And my program.
Go ahead.
Go ahead. Oh, I was going to say my residency gave us an option to do either research or an enfolded fellowship. And I chose to do the enfolded fellowship, and that's where I did my deformity training.
Yeah, that's great.
Could you explain what that means for some people listening or watching? I don't enfolded.
Yeah. So So infolded residency is, I don't know if it's always been around, but infolded residency is because you have a 7-year program, a lot of programs would give you the option to do a research year. So instead of doing kind of computer research or bench research or whatever it is, clinical trials and all that stuff, some people want to opt to have a more subspecialized training in that particular field of neurosurgery. So the subspecialty that I wanted to go into was spine surgery. And particularly, I really enjoyed something called deformity surgery. So within those 7 years, instead of having 1 year where you're going to do just research, that 1 year can be dedicated to that training. So they call that an infolded fellowship.
Got it.
And I did that training within my residency. So I could come out of residency saying I'm a fellowship trained deformity spine surgeon. But in addition to that, I decided to do a second fellowship because I wanted to have, now infolded fellowships and postgraduate fellowships are different. So now it's not really recognized the same way anymore. So I decided I would just do both. I did an infolded one, and then when I finished, I can say that I have a postgraduate fellowship as well. So it's 8 years of training total.
So when you're saying deformity, you're just so people know, it's like scoliosis, things like that along
Correct.
that line, just something people would know.
Correct. Yeah. So anytime the training that I had was in adult deformity. So a lot of degenerative stuff. So a lot of times we would do things like pedicle subtraction osteotomies, vertebral column resections, and stuff like that. So these are very, very big, complex cases that are usually done in academic institutions where they're considered to be some of the most complex types of spine surgery that a person can do. So, you would take a chisel and a hammer, and you would effectively break a wedge of a vertebra off of a certain level so you can correct a person's spinal alignment. And I was just so in love with it because there is a quantitative measurement to how somebody's spine should be aligned. And I was really interested in that. So I had an attending that once told me that all forms of surgery is an attempt to take the body back to its original anatomy. If you take out a tumor, you're trying to take it back to what it was before it had the tumor. If you're trying to do a laminectomy, or a microdiscectomy, you're trying to take it back to the point where it was, where the disc wasn't there. It's all trying to create an environment where it's normal anatomy. That's what you're trying to do. All surgery is like that. And that's why I was really interested in doing deformity surgery, because you have people that just have horrific alignment and their life is horrible. Their quality of life is miserable. And you really feel for these individuals. And they'll come in and they say, look, I'm 60 years old and I used to be able to hike and do all this stuff. And now I sit on the couch. And you can see it in their face. They're really, really, really sad. You try to give them as much of that normal anatomy, remove as much pain as possible so that they can go back to the things that they love and enjoy their life. It's a quality of life surgery. That's really what deformity surgery is. It's not a necessity a lot of times. It's really just for improvement of quality of life. And sometimes it's cosmetic too.
Yeah. How do you like the length of the surgeries? I'm sure they're fairly long. Like how many
Extremely
hours?
long.
Well,
Yeah. So
I
was, so it depends on the case, as you know, but sometimes we can do a fusion surgery that's from T4 to the pelvis. And that is, for people that don't really know, that's from like the base of the neck basically to the pelvis. And so you basically have screws at every level, and you can have 2 to 6 rods total in each 3 on each side sometimes. And those surgeries are incredibly complex, incredibly challenging. Those can take 12 to 14, 16 hours to some people.
Yeah.
So they're very, very tough. Yeah. I was training with a guy that was an orthopedic, he was a neurosurgeon, but he did a fellowship in orthopedics. And they really focused a lot on efficiency, OR efficiency. So the guy that I trained with, when he was in the OR, those cases that would normally take 14 hours, he could do in 3 to 4. And he was phenomenally talented. I have nothing but positive things to say about that individual. Truly a gifted surgeon at everything that he did. So he took those really complex surgeries that if I were to do by myself would take me 12 hours. He could do it in 3 to 4, in a third of the time.
Yeah.
And
but you'll find as you get older, you'll do them a lot quicker. I mean, when
yeah,
it's just experience. I don't, how old is he? Older? Or?
He is. He's significantly old. I mean, not crazy older, but yes, he is older. Yeah.
But you'll learn. You'll see like a CDF, a neck, single level neck fusion. Some people get out of residency, it takes 2 or 3 hours, and then before you know it, they're 45 minutes. But depending on your training, but I'm just saying you'll see your times change, and it's just because of experience.
Yeah.
You learn how to stop bleeding when you first get out and you're in there by yourself, wait till you get bleeding. It's a totally different arena than when you know somebody's there to bail you out. When no one's there to bail you out, it's much different trying to stop the bleeding, because things wander through your mind. Like, what if I can't stop it? There's nobody here to stop it for me. And so it slows you down. I mean, a lot of that stuff slows you down. And then as you gain your confidence, you do more and more cases on your own, then things will speed back up, and then you become very efficient.
Yeah. You get a lot of intrusive thoughts during surgery, I would say.
For sure.
Unwanted intrusive thoughts. Yeah.
Crazy where we've come from. We recently did an episode, my dad and I, just on like the history of brain surgery and just neurosurgery in general, and just how where it's evolved from, and really until like the 1800s and early 1900s, you didn't have this. That's kind of when neurosurgery first developed, and you had this certain things you needed to be able to do stuff like that. And obviously Harvey Cushing, but it's just wild. Like, if people even 500 years ago could see you doing an awake brain surgery or a very complex spine surgery, and they would think it's like the future and some sci-fi thing. And now I think we take for granted, not just in neurosurgery, but just modern medicine in general. We never knew, we didn't used to know hundreds of years ago that there's these invisible things, bacteria, causing people to die and have diseases and stuff. So it's just fascinating. And it kind of leads me into a question I have for you as someone who just went through residency, is kind of, what are you most excited about? Like, what technology in neurosurgery or otherwise in medicine are you like kind of most excited about, or do you think has like the most potential for like an impact?
Yeah, that's a phenomenal question. I think you're probably going to get similar answers if you were to ask another neurosurgeon, because one of the most groundbreaking things that I think has been developed in neurosurgery is the implementation of, number one, artificial intelligence, but more so augmented reality. Augmented reality, I think, is going to be a game changer, and robotic surgery. So now we do already have robotic surgery. Like, there's robotic spine surgery that will help you place pedicle screws. You can also there's something called a ROSA, which is a cranial robot that can also help kind of guide a robotic arm for where a craniotomy should be done, or where to get a certain biopsy from, and stuff like that. But augmented reality is what I'm really excited about. So, there's these glasses that they're made by different companies. There's a company called Augmetics, and yeah. So exactly. So there's several different companies. Augmetics is one. I think another one is Surgical Theater, and like a bunch of people that make these different glasses that you can wear, and it takes all the guesswork out of trying to figure out where to do a certain procedure. So to anybody that's watching that doesn't really have an understanding of how certain things are done in neurosurgery, a lot of times if there's like a tumor somewhere, in a particular part of the brain, back in the day, the really talented, skilled neurosurgeons would just have to reference the location based on anatomy. We didn't really have stealth navigation in the past. So you would have to identify where it is based on certain parts of the skull, and then the ear, like external anatomy and also internal anatomy. And they would basically pinpoint where it is, and a lot of times those surgeons would get it. Nowadays, we have something called stealth navigation. So stealth navigation is you take an MRI and a CT scan, or one of either, one or the other, before surgery, and then you put it into a computer that has cameras. That camera will look at a reference array. There's like dots on a person that is attached to a person's body. The computer will take that CT scan or that MRI, and you have like a wand that you can use to kind of figure out where you are in the brain. So you can put it on someone's head, and you can look on the computer, and it'll show you exactly what part of the brain you're on if you're pointing to that part of the head. So if somebody has a tumor and like just in the middle of the convexity here, somewhere in the frontal lobe, whatever it is, or like near the motor strip, stuff like that, you can take the wand, put it right there, and then you'll know, okay, this is where I need to make my craniotomy. So then you will be able to map out exactly where the tumor is. You will make the appropriate size incision and do all that stuff. So that was a groundbreaking thing. That was a huge revelation in neurosurgery.
Because in my training, we didn't have that. We didn't have stealth and stuff. So we were those doctors that you have to know your anatomy, and we would figure out where, based upon anatomy, we would make our craniotomy bigger to make sure we were there if we were going
exactly.
Into a brain tumor. If we had a tumor deep in the brain, we had to do a biopsy. There was something called the CRX system, which is an archaic big metal cage you would put on people's heads, and we would take these handwritten coordinates and enter them into a computer by hand, and then those 3D those coordinates would give us a little trajectory that we would put onto the skull and follow it down. But if you made an error entering that stuff in, human error. I mean, you're wrong, you know. So there was no
Yeah, yeah,
replacement for knowing your anatomy, knowing your depth. You couldn't trust the system. If it said go 11 centimeters and you're way too deep, you have to know that that's way too deep. You have to know in your mind. So
absolutely.
there's pros and cons to all this. I mean, you still got to know your anatomy. These systems are great
100%.
and they can pinpoint it, but you can never forget common sense in your own anatomy. Sorry.
Oh, for sure. But it's also not always accurate, right? So,
Right.
sometimes,
Exactly.
the reference array that I was talking about, like those floating dots that you can have on someone that's attached to the head holder or whatever it is, sometimes it's
Yeah.
easy to bump one of those or whatever it is, and it gets miscalibrated. And you might not realize that it's miscalibrated. So then if you are miscalibrated, if you are putting the wand somewhere, the computer will not always know it's miscalibrated and it won't tell you. There's no warning.
Yeah.
So you'll put it thinking you're one place when in reality you could be several centimeters away. Being several centimeters away might not sound like much. In neurosurgery, it is miles. You might as well be
Yeah.
miles away, because centimeters and millimeters is the difference between being able to walk after surgery or being a hemiplegic for the rest of their life. It's a huge difference. So nowadays, that is the standard of care, is the stealth navigation, doing all that stuff. There are people that don't use navigation because that's how they were trained and they're very capable and they can do it without it. However, nowadays, a lot of people are being trained on this new navigation software. Augmented reality will take away this need for the wand entirely. So now you can wear these glasses and you can look at the patient and then you can see the MRI as an overlay onto the patient's head. So there's no need to look at a monitor, look down, look this, and try to like reference it yourself. You just know exactly where that thing is. So you look at the patient, you see the tumor, you say, this is the size of the incision, this is the size of the craniotomy, this is where the mass is, and this is how we're going to get to it through this approach, whatever it is. And I think that is going to be the next version of the stealth navigation. So when stealth came by to help us with neuro navigation, that was one huge step in neurosurgery. I think augmented reality is going to be the equivalent of that going forward.
Yeah, and it's really spectacular because I about 3 or 4 months ago I had a chance to put these glasses on, and when we put screws in people's back, we have to put it down a structure of the bone called the pedicle. Just think of it like a bone corridor. And if you're outside of that corridor, you can injure a nerve or cause a spinal leak, or go into the spinal cord. So these augmented glasses, when you look at it, you see a 3D rendition of the spine, and you can see the pedicle. And as you're putting a probe into the patient's body, you can follow that right down through the pedicle, live with these glasses on.
It's so cool.
You're looking into the human body with millimeter accuracy. It's unbelievable.
Yeah, it's X-ray vision without X-rays. I made a video
100%.
similar to this in the past, and I made a video similar to this where I was talking about how, it's kind of a way of getting X-ray vision. I was talking about the glasses, and then people start saying like, "Oh, how is that safe? You're shooting X-rays," and I realized I should have been more careful with the words that I'm using. So it's really a scan that's obtained before surgery that is then integrated into the software of the glasses, which will then portray an overlay onto the patient of that scan onto the patient. So if it's an old scan, the anatomy might not be accurate. It might be different now. Especially if it's a tumor that has grown, things could have shifted.
Yeah. I think something that's super interesting too. We were talking to Dr. Pilcher, who's the neurosurgery chair at University of Rochester, and he's actually who trained my dad. And they have someone there now. One of the things they do is Dr. Stone, he's got a company, and they're really good at 3D printing. So they can, if someone has a complex brain malformation or tumor, right, Dad, they can 3D print the exact replica of it, so the surgeon can practice on the 3D printed brain before they do the actual surgery.
They have a lab that they work in. It's really cool. Yeah. And have you heard of the models they have? They have it there. So to teach residents how to operate, maybe you have this in your residency. I mean, we have nothing like this. But so say you're going to just do a laminectomy, right? So you cut through the skin, obviously, and it'll mimic bleeding, and it's supposed to feel like the texture of skin. And then you go through the muscle, which is a different density. And then what you do is when you start to take the bone off, when we're taking bone off, we use an instrument called a kerrison. You can use a drill, but just say we're using the kerrison, so it bites the bone away. You're pulling bone off the back of the spine. Well, it has pressure sensors on it. And so when you're taking these bites of bone off, it tells you how much pressure you're putting on the spinal sac, which is incredible.
Oh, wow.
Because then it teaches you, and they'll have contests, which resident can have the least amount of pressure on the spinal sac. Because if you're operating over a spinal cord, you can't be pushing this thing down on the spinal cord. You're paralyzed.
Exactly.
So this model detects the amount of pressure that you're putting onto the spinal cord and the spinal sac. So it's feedback into your body, so get a feeling what's right and what's not, and it's just additive, right? I mean, there's no replacement for experience, but certainly it's something that you can do outside of operating on a person to learn how to operate. It's
Hmm.
really cool. I mean, all
It's
this stuff has
incredible.
come up.
And
Yeah,
I definitely did not have anything like that, but that would have been extremely helpful. And, people don't really understand sometimes is that when a neurosurgeon does a very complex procedure, like a bypass, for example, um, th- at one point, it was their first bypass. So
right.
you have to do it on a person, and there's no getting around that. You don't become an expert in something without having done it several times, but at one point, everybody's a beginner. That
Right.
expert in bypasses was a beginner at one point, and he did it on a human being. And so, that's one of the benefits of being at an academic institution as a resident. And patients, I think, understand that, or if they don't, they need to understand that, is that, there's a very strong chance that you're going to be operated on by a resident under the supervision of an attending.
Mhm.
And so they have to kind of sacrifice certain things in a way to be able to allow that resident physician to learn how to do some things. I had my first laminectomy at one point. I had my first PSO at one point. And I put in my first pedicle screw at one point. I did my first cranie at some point. And all these individuals are individuals that have contributed to my level of education for the rest of my life. Those
Yeah.
people gave me that thing that I will now have and carry forward to the next person that needs it.
Yeah.
I think too it's something interesting I heard my dad say recently is we were talking to some University of Rochester neurosurgery residents, and just now when he's just operating by himself most of the time, like he kind of misses residency and getting and learning all the time and getting to operate with other people and talk with like doing surgeries with other people, right, Dad?
Yeah, so when I trained, we didn't do as much spine as they're doing now in trauma and stuff. So stuff that you probably do secondhand, we didn't do as
Mhm.
much of it as they're doing now. And so it's amazing to go back and just see 30 years later all the different specialties now there, and how all the new techniques that are out there that I didn't learn, when I was younger. And it's fascinating. It just gets you reinvigorated about all the stuff that neurosurgery does, because neurosurgery is always on, will always be a field leading medicine for technology. I mean, neurosurgery is always on the
Yeah.
cutting edge of technology. And so it was really cool to go back and see all this new technology, and it'd be great to do it again, just to learn it, I think. I mean,
Yeah. A lot of new stuff.
He jokes about going back and doing residency once he retires.
No shot. No shot. I could not be paid any amount of money to do it again. That was
yeah, but
tough.
then don't you think it went fast? I loved residency. It went so fast, but it was just that time in my life where you just assimilate. You're like a kid. You're just assimilating so much information all at once, and the camaraderie with my fellow residents, and we were like a tight knit
That's very
family. And
true.
some of my best times in my life were in residency, and
You need a decade or
at
two
work.
for it to be past to then look back.
You're right.
Yeah.
No, you're 100% right. And Kevin, I think said something very important here is that you don't realize how good you have it until you're out of it. So when I was
Yeah.
in residency, I couldn't wait to get the heck out of residency. And now that I'm out of residency, I'm considering going back to work there permanently. So like, it's
Yeah.
almost like I don't want to leave in the first place. I thought I wanted to leave, but you are absolutely right. It's a
Yeah.
7-year family that you created. And those people are some of the closest people. They know you better than your own family knows you. At my graduation
100%.
ceremony, for sure, they show like pictures and stuff of me with my friends from residency and stuff, and they said things that my family had no idea that I did, about me waking up early in the mornings to go work out and exercise and do all this. My personality. My family, I was so far removed from my family because I didn't talk to them that much, because I was up at 3 and I didn't sleep until midnight sometimes. I'm gone for 7 years. I was gone. And so they would just not know that I was doing all this stuff behind the scenes, but the residents did, because they saw me every day.
Yeah.
And so they know exactly what my morals are, where my moral compass is, what my ethics are, and what my personality is, and who my friends are, who my family is. They know all these things about me, and they became the new family. You're absolutely right.
What do you just for people out there, they'd probably be interested. Like, what do you like most about neurosurgery? If you had to pick one thing you like the most, and then what would you say?
The fact that it's incredibly challenging, in my opinion. You have to have a certain level of you have to be a little bit of an adrenaline junkie, in my opinion, to want to do neurosurgery, because There is no neurosurgical case that's the same. I mean, a lot of times you can make the argument that a laminectomy is a laminectomy or a cranie is a cranie. Sure. But anatomy is very, very different. People are very different from one person to the other. And you have to adjust your surgical technique to be able to accommodate that individual. So I made a video about this a while ago. You have to study the anatomy of the patient before every surgery. Every surgeon, no matter who it is, every neurosurgeon will sit at the computer before making the incision and will scroll through the images to look at the person's anatomy. Even if they've seen it 100 times, they're going to sit down before making that incision again because they want to remind themselves and make sure that they're doing the right thing and scroll through and know how they can adjust their technique. Every single time, it's a different plan. Yes, we're doing a laminectomy, but there's a lot of different variation to it. How thick is the ligament that you're going to be doing? How thick is the bone? How big are the facets? They're going to be degenerated. There's going to be facet arthropathy. There's going to be enlarged, overgrown facets that are going to get in the way. How are you going to get around that? If you're going to do a cervical thing, where does the vert enter? Is the vert entering at C7 or at C6? You have to know where all that stuff is before making the incision. So that is really the one thing that I like, is that no one surgery is really ever the same. What about you?
Oh, I would say the same thing. I think that's why part of the reason I went in neurosurgery was some personal reasons, but also it's the most challenging field I thought there was. And it's like it was the most challenging thing I could think of to do in medicine. And I think our type of personality gravitates toward that. And
Yeah.
In some regards, you want to be the best. Like you want to be if there's something out there that's the best, you want to be out there. And I thought the things that we can do to help people, just like your simple story about your dad and what it did for him and what simple surgery changed his life. It's just amazing what we can do. So that's what I liked about neurosurgery.
Absolutely.
But
and I recently,
but it was scary too. It's a scary thought to think that you're going to be operating people's brains and spine. And it's scary to push yourself to that edge to say, yeah, I'm going to do this and commit. It's tough to make that decision. I thought about plastic surgery for a moment and I said, it's just, I wanted to do neurosurgery, but it's scary thinking that you're going to actually apply to a residency, start training, and be a neurosurgeon.
Well, and the fear of failure, right?
Yeah,
I mean,
absolutely.
neurosurgery is considered one of the hardest fields. There has to be. I
Absolutely.
have one of my friends, he wants to go into neurosurgery, and he's a third-year medical student. I was just having coffee with him this morning, and no matter what, I think there is that strong desire. You have to do every single thing and work as hard as you possibly can to set yourself up with the best chance of success. Because it's so competitive and it is very, very hard, but that's who you want to operate on you when it comes to the brain and spine. Because like you said, there is no room for error in the way that there is in another spot, not in the brain. You can't be, oops, I just made a little mistake.
Yeah. I think me and Dr. Hefflinger, I think we're going to agree on this, in that I think that people nowadays that are in residency don't really appreciate the need to kind of suffer a little bit in residency. The type of person that I want to do my surgery is going to be the guy that was in the trenches, getting yelled at by an attending, having to make a life and death decision, whatever it is. I want that guy. I want the guy that's trained to be a rock. Because when you go into residency and when you come out, I firmly believe you are a completely different person. When I came into residency and when I graduated, I transformed everything about me. Physically, emotionally, mentally, the way that I did everything completely changed. And in my opinion, I think it's for the better. I want the guy that has been through the rigors, that has been transformed over the years to be a solid foundation of medical knowledge and an individual that can make the correct call under very stressful situations. Yeah. Those situations are not going to present themselves in a very very calm environment, in a very subtle OR. The type of environment that sometimes you're in as a resident is one when there is massive hemorrhaging and the attending is yelling at you because your hand is shaking because you can't hold the sucker properly. That's one of those situations. You want the guy that's nervous that the attending can't see the vessel so they can suture it. That's going to be the guy that in the future is going to remember that moment, because that experience is going to harden that individual. Yeah. And so that individual, when they come out of that surgery, is going to say, that was horrible. Yeah, it's not supposed to be easy. It's not supposed to be simple. Yeah. That's the point of residency. And so I think people need to remember that. Yeah.
Well, and I think neurosurgery has to be number one in your life. You can't have two number ones. And there's family, and you can be a good husband and father, but you can't be a part-time neurosurgeon. I mean, you just it has to take precedence. When people need you, you have to be there no matter what. Ask Kevin how many times I've missed events of his because I was at work, and it's just, it's the way it has to be. But I think, I think as kids grow older, they understand that. I mean,
yeah, we've talked about that. That's just something you have to understand that because again, that's who you want doing surgery, and it has to be, you have a obligation when you've trained to become a neurosurgeon that's got to be your first priority of, if someone needs emergency brain surgery or anything else like that. And so I think you do understand, but it's kind of tough. And I think that would kind of be interesting is, obviously there's different ways, but when you're working really hard, have you had anything in terms of just kind of balancing work and life where there's probably highs and lows? Is there anything that you go to for anyone else who's maybe in medical school or residency, and what's worked for you?
Yeah. So are you asking, like, have I missed certain things in life because of my dedication to neurosurgery? Is that the question?
Yes, that, but also like it sounds like you work out. Like, is there certain things you
Oh, I
try
see.
to do to balance so you don't just get completely burned out and
Yeah.
where you can't keep going?
Yes, for sure. So yes, exercise is a big one, but I'm also a massive introvert. So a lot of times the thing that really rejuvenates me and energizes me is to just be left alone. So I want to just be at home in the quiet, and sometimes I'll just whatever watch something on TV, or I'll read a book that I really wanted to read. I also, when I was a college student, I really enjoyed playing video games. So I didn't really have a lot of time to play video games, but if I ever get an opportunity to sit down, like I have a PS5 and I've turned it on maybe twice, but I'm in love with the idea of the person that I was when I had the time to play video games. And I feel like the minute that I stop buying video games is the time where I start admitting that my life has changed and I'm no longer an individual that enjoys things outside of work. So
Yeah,
I still buy the thing to have it if I can ever use it, but
yeah,
I can never commit to it. But again, I'm never going to stop doing it because that's the point where you admit that you're not
yeah.
that person anymore.
well, you
I
want to
like
hear something? I got to tell you something interesting. So I was reading somewhere, I read it, but so surgeons who actually play video games, like the younger generation, they have like a 30% less complication rate
I
because of
saw
that.
that.
Isn't that crazy?
So it's
And
not a
but
small number.
it makes sense. But it makes sense, right?
Yeah.
Because I mean, you're
Yeah,
so
yeah.
used. It's eye-hand coordination. That's what we do. So I
Absolutely.
agree. I can
Yeah.
see how that really would make sense.
yeah,
Yeah, it's not a small number. I mean,
No, not at
25%
all.
is a huge number. So like,
Yeah.
yeah,
that's something to be said about that.
Yeah.
But I do know what you're talking about, and that is a very interesting paper. Yeah, I mean, so kudos to whoever designed that
Yeah.
paper. So good for them.
I like the thought there of like it's having something in your mind, even if you barely ever get to play video games, but it's keeping
Yeah.
that thought in your mind of like that's like you're going through a desert and there's just if you can always just keep there's an oasis
Yeah.
somewhere where there's some water I can go drink.
Yeah,
It
for
just
sure.
keeps you going just a little bit further, even though if it's always just a little bit unattainable to actually have time to play video games or just
For
every once in a
sure.
while.
Yeah, yeah.
It's a cool thought.
Here's a fun question to think about. So you're done with residency. You did 7 years. Now you're in your fellowship.
Hmm.
Going to be on your own next year. So if you had to go back to your first year nursery resident self, what would you tell your first year
Man.
residency self? Like you've learned all this knowledge and you learned, so what would you tell yourself? Like just
Oh
anything.
my God.
What advice would you give yourself?
That is such a profound question, and I think it is a phenomenal question because I think about this all the time where I say, like, I wish I could just go back to that version of myself because there were times where I remember I would be sitting. Okay, I'm going to tell you something. So during my first year of residency, I worked. Again, this has nothing to do with my residency program. This is just me. My
Yeah.
residency is completely absolved of all this responsibility. This is me. So I worked, I would say, probably 20 hours every single day. And that's because I would wake up at 4 in the morning, and I didn't even work out my first year of residency. I would wake up at 4 in the morning. We'd go round at 5,
Yeah.
and then I would go spend the entire day in the ICU as a junior resident. And all I would do is take care of the ICU patient. It was just me as a resident. I had no advanced practice providers at that stage of my career. There was no attending at that time. We sometimes had an ICU attending that would oversee things here and there. but they weren't, the primary attending for the patient. I was really the person that was taking care of them my first year out of medical school. I would have to write all the notes, do all the orders, do all that stuff. And of course, everything is run through the chief who speaks to the attending, but I was really the person doing all that. So first year of residency, 24 ICU patients, that's what I was doing. I would wake up at 4, go round at 5, and I would get home. I would not have time to write the notes for 24 patients because it was such an intensely busy ICU. So I would not have time to write any of the notes. So I remember I would go home at like 11 o'clock and I would sit on the couch and I'd sit there, take out my laptop and start writing the notes on my own time. And I wouldn't get done until about 1:30 or 2 in the morning. And then I would sleep and I'd wake up again at 4. And I went and I did that for like months and months and months on end until I became more efficient to the point where I was able to write the notes during the day. But it was such an intense process. During that time where I was sleeping 2 hours a night for months, that was the time where I have never come so close to quitting anything in my entire life. I was so incredibly close to just saying, this is not worth it. And I was just going to say, forget it. I'm done. I'm going to go do a different specialty, whatever it is. I want to go to that version of myself and tell that version of myself that this intense struggle is going to create an individual at the very end that is unbreakable and unshakable during the hardest of times. And this is the type of thing that I was talking about earlier when I said residents don't appreciate the struggles of residency. I didn't appreciate the struggles of residency when I was going through it, but it formed me into the individual that I am today that does not accept mediocrity. There's no room for mediocrity in neurosurgery. You breed excellence in neurosurgery. Neurosurgeons, 100% of the residents should be excellent if they're graduating their residency program. Yeah. And that's part of the training process. So I want to go to that version of myself and tell myself, this is worth it. You're going to make it. You're going to be a lot happier. You're going to have the life that you want.
That's a great thought and it's great advice. And I think that applies way beyond neurosurgery. If you can get through the hard things in your life, the person who comes out the other side is so much better off. I like thinking about the idea of hard now, easy later, or easy now, hard later. Anything you do that's hard now usually leads to it's delayed gratification. It's working out. It's hard now. It sucks. It's better life long-term. Eating healthy now might suck, but you're better off long-term. So the more you can do stuff like that, it's just it's deeply satisfying. And knowing that you can get through hard stuff, I don't know anyone who's ever mad that they worked out. It might suck while you're working out, but after the fact, you always feel good. I always feel great after. I won't want to go run. It's winter here in Ohio right now. It'll be like 10 degrees out. You don't want to go run, but once you're done running, then you feel good. You take a shower and then you're ready to keep going.
Well, and I think it's it's a cumulative effect, right? So when you're day to day, it's hard to see in the future day to day because you're focused on your day to day. It all adds up. So it's cumulative. So over years, that's what training is about. Over years, when you look back, you go, wow, day to day sucked. And I never thought I'd make it through the day. But when you look 4 years of that, you go, wow, look what I accomplished. I mean, it's accomplishment by additive effects day by day by day. And so you can't give up. You can't give up for any individual day.
Agree. You don't realize how much you're learning on a specific day. Until later on in my training, when I was like a PGY5 or whatever it was, I started to realize just how much knowledge I gained, because then you have junior residents asking you questions that you think are simple, but then you take a minute to realize you didn't know that when you were at their level either. Right. So I start thinking back when someone asked me a silly question, I'm like, wow, that was a silly question. And then later on, I pause and I'm like, would I have known that if I was a second-year resident or a first-year resident? The answer is no, oftentimes. So then it makes me realize, I'm like, wow, I actually really gained this wealth of knowledge, even though I don't realize it. It's because you're seeing the same pathology over and over, and you're starting to develop a pattern.
As a segue into kind of social media stuff here, I think what's really interesting is what you're describing there. Like for my dad, something that's so obvious to him, I think that's why we can make good content sometimes, because I will think about things. I'm like, for myself, who's in between, and then for my friends, what they think about neurosurgery and people, just random people, I'm like, he's like, no, I don't care about that. So I'm like, no, that's exactly what they care about. And breaking down these things in ways people can understand. And I think that's what you guys both do with the content. People want to kind of inside look at what all that is. It's crazy to them, but also you have to think about how many years and how many hours and reps you two have put in learning, like from the base up, all your medical knowledge, going through like practicing surgeries, having mentors. It's quite fascinating. It's just, I think that's what people really like is when something that's simple to that person, if you can open up and then kind of explain it, it gives people a look into the field.
Mm-hmm.
Let me ask you a little bit of a serious question, because I've been doing it my whole life, and you're doing it now. But how is it for you when someone has a tragedy and you're the guy who has to talk to the family or the patient that has newly diagnosed cancer, or a child that comes in that's been in a bad car accident and they're brain dead in the emergency department, you've been consulted, and you got to tell that mom and dad that there's nothing that we can do. And so how has that affected you, and how do you deal with it, and how do you decompress? Where do you stack it away in your mind? Some people have a spot in their brain, I think, where they put it away and it stays there until they need it. But just interested. We're all different, but
Yeah. I wish I could tell you that I'm like resilient from that kind of stuff. I'm not. It really, really affects me deeply. And it's hands down the hardest thing I think about being a physician. It's not the hours and all that stuff that you got to do. That stuff is challenging. The hardest thing is having to tell a parent that their child is gone. The other thing is having to convey a diagnosis that has a very poor prognosis to an individual. Um, I, of course, as a resident, have had to do that on several occasions, because sometimes a patient comes in the middle of the night with an inoperable brain hemorrhage, and whatever it is, like a pontine hemorrhage, something that you don't really treat. Stuff like that. When somebody comes in and they have stuff like this, it becomes your responsibility to tell a family that their loved one who was okay this morning, 12 hours ago, they were fine eating breakfast with you. That person is now no longer considered legally alive. It's done. And so you have to tell them that just verbally. And then their reaction, understandably, is incredibly passionate towards that individual, as it should be, because it's their family. You take that energy as a physician as well. They express frustration and anger towards the surgeon a lot of times, which again is understandable. The best thing about my program is that I was trained in a way to be able to deliver tough news, because we had to do it so often because of the cases that we would see that would just come in, whether it's a trauma or whatever it is. We were a very vascular heavy program as well. So sometimes people can have an arteriovenous malformation that just ruptures in a part of the brain that is essential for life, and that person is no longer considered alive. They're brain dead. So I have had to convey that type of information to people on several occasions. And I would say the hardest thing is having to do it on a younger individual, for sure. But when I leave that room, I wish I could say that I bounce back and I go and I talk to the next one, but I don't. I'm like, honestly, it's hard to talk about it even, because I do it so frequently. And I have to go in and I have to tell these families that their loved one is gone. And I want to not carry that sometimes, but I do. I think about a lot of the people that I've had to say that to. I think about them on several occasions. I know the names of several of them by like first and last name. I know their names. I carry that burden with me. I try not to let it affect me, but it does. And it's never, thankfully, knock on wood, very, very, very seldom is it a surgical complication. I would say that's one out of 1,000 times that I've had to do something like that. But it's always the tough ones are the ones that are unexpected. Because when you're taking someone into surgery, there was always a chance that something could happen. You can always prepare the patients for what could happen during surgery. There's no preparing somebody for a cavernoma hemorrhage in the medulla or whatever it is in the midbrain. Stuff like that is life-changing for everybody involved.
Yeah, I think it is a tough part of the job. One thing I always have to remember: it's not you don't give people diseases, and all you can do is try to deliver that information and then give them a chance to absorb it. I mean, the thing that I've noticed the most doing this in the middle of the night or whenever it is just, you kind of get an idea of what they understand, and then you really just give them time to absorb it. And they're never you're not a big part of that whole scene. I mean, that's their emotions right there. And I kind of answer what I can for them, and then you kind of have to just let them handle the rest, and you should never get used to it, because it's part of you that if you get used to it, I don't think you're human.
That's what makes you human, right?
Yeah. Absolutely.
But I think that's a huge thing in our society is that like doctors and first responders and police and everything else, there's only a small subset of our kind of population that sees all the tragedy, and they just have to kind of deal with it. For then the average person, you don't see stuff like that. It's just not part of that. So I think I always try to think of stuff from the perspective, if someone had a bad experience with a doctor or a bad experience with someone in a different profession, you never know what's going on in someone's life. Like that doctor may have had to just deliver the worst news in someone else's life, and then they have to come talk to you. So it's always good to just kind of, I think, just give people the benefit of the doubt instead of, assuming the worst.
Yeah. I mean, at least with things like a glioblastoma, for example, or now it's called a high-grade glioma based on the WHO or whatever it is. We all know what it is. GBMs, those are the diagnoses that are really difficult to deliver news, but there's ways as a surgeon where you can soften the blow a little bit, because you go in there and you say, you have this very aggressive form of cancer. But the way I was trained is to never leave the person feeling hopeless. You tell them there are things that can be done for it. Right. So anytime I deliver news like that, where I say, hey, there's this form, there's a mass, it's a lesion, it's suspiciously aggressive on imaging, but this is not a death sentence. This is the beginning of a journey that you're going to have to take with us if you want it. I say, we provide you with the tools to kind of battle this thing. And then we go through the steps, and I tell them kind of what we can do, Stoop protocol and the resection and all that stuff. There's ways that we can combat this high-grade glioma. And I try to tell them that there are options that they can choose from. I try not to leave them without any options. I say there are 3 things that we can do. We can do nothing for this at all if you don't want to have anything done. I say, but I don't recommend it. Then I tell them what's going to happen. I say, you can have a resection of the mass, which would involve things like chemo, radiotherapy, and stuff like that. You can take some time to think about it, go review the imaging, talk to somebody else, get a second opinion, but come back and all that stuff. Give them the options. That way they feel like they're in control. And that type of delivery of news is a lot more digestible for the patient, I think, instead of having to deliver something like the loss of a loved one.
But not to get too deep, but I think just what you do need to do is you need to be honest with people too, to some respect. You have to give them expectations. And I don't try to, when somebody says it's a benign cancer, there's not a benign cancer. I mean, people use that term. So cancer is cancer, cancer is bad. So you have to be honest with people. And those are tough. I think that's what we don't learn in training, is how to talk to people about death and really bad things and be honest. I mean, you didn't give them that GBM, but it's a horrible disease to have. And really, essentially, everybody dies from that eventually. It just depends, what kind of treatment you have and how long that treatment lasts. But I mean, those are conversations that are hard to have with people. But I think being honest with people, I've found to be the best thing to do, because it's a tough conversation, but then they can make the best decisions for themselves. Some doctors mislead people to think, you're going to live, another 10 years if we do this, and that, when maybe they only have 3 months left to live. And it's, everybody has a conscience, right? You have a conscience, I have a conscience. Some people can't deliver that type of news without killing their own conscience, and they just can't do it. So I think that's the toughest part of what we do, is try to be honest with people and go against what we may believe, I guess. I don't know.
Yeah, no, you're absolutely right. Yeah, that's very important. Setting expectations early on so that they can make the right decision, because you're right. What if they only have 6, 7, 8 months left to live? Are they going to want to spend 2 of those months in rehab after neurosurgery recovering? That's the question. Yeah, for sure. I agree with you.
Well, I think something that's big there that I've heard you say before, Dad, it's important too, how you deliver the news. Like, you should never be delivering news to someone just there by themselves. Like what happened with your mom when, she just found out she had brain cancer when just by herself. So, right. And that's an experience of yours that shaped kind of how you are as a physician.
Yeah, definitely. We all get busy, but to go in to talk to somebody alone when they have no idea what's going on, without family there, and then deliver that type of news. So I always try to, it's hard sometimes, but make sure there's a family on the phone or a family member there. If I go around and no one's around, maybe I'll postpone it till the next day. And as you know, Dr. Z, seem like to be the ones a lot who deliver that type of news. A lot of doctors will defer to neurosurgery to deliver that type of news. And so
Yeah.
it's something that you have to do as a neurosurgeon, not get used to it, but it's something you have to do because a lot of other doctors won't do it, you know?
Yeah.
Yeah.
For sure.
So what's the future hope for you? So you're you're in your fellowship, and then what are you going to do next? Other than
So
social media?
I'm in the job market now, so I'm trying to check to see what's available out there.
Uh-huh.
Trying to figure out where I want to end up, and I'm in the interview trail right now, probably doing these interviews, and it's interesting to just kind of see the diversity and the changes that
Yeah.
can happen from hospital to hospital and how they
Yeah.
prioritize certain things. So that's kind of what I'm doing now. I got to find a spot that I'm gonna like living for potentially the rest of my life, and
Yeah.
settle down and do it.
Where do you like
Could be Toledo.
what yeah, right. Yeah, not
Maybe.
what part of the country do you like? Like, do you like warm weather, mountains?
No, I'm a city guy. I didn't
Yeah.
know I was a city guy until later.
Wow.
I grew up in a very, very small town of about 10,000 people in South Carolina, and I spent my high school years there, my college years there, and I didn't really experience a big city until I went to residency. And when I was in residency, I
Which
lived
was
in a very
Chicago, right?
metropolitan. It was
Chicago, yeah.
Chicago. I did
Yeah.
residency in, yep, downtown Chicago. And I was very fortunate to kind of experience that city life. And when I stepped foot in Chicago, it honestly felt like I should have been there my entire life. I
Wow.
absolutely loved it. So Chicago was fantastic. So anything that's kind of in a very nice metropolitan area. So I'm currently in LA. I really like working in LA as well because obviously the city life is very important to me. So
Yeah.
who knows? I might end up in one of these areas. I honestly have no idea. But like I said, I've been to Toledo in the past.
Yeah.
Toledo is not bad. I'm a fan of Toledo. I think it's great.
We get all 4 seasons, you know.
Yeah. And what are your hobbies? Do you like to go skiing, hiking, scuba diving? Like, what do you like to do?
Man, I'm not as cool as you. No, so yes, I do enjoy hiking. There's a bunch of hiking trails here in LA, so I gotta
Yeah.
go experience the national forests a little bit, national parks. I really want to be able to uh, explore and enjoy life for what it is outside of the
Yeah.
hospital and kind of go do this whole nature thing. And I saw that you guys are big hikers, and I saw that you went to Kilimanjaro, right?
Yeah.
Yeah.
It was awesome.
So we're not. That was a really cool experience. There's nothing like that in Toledo. It's very flat around here, but that was
Still,
awesome.
man, I mean, you get to experience all that stuff with your family and all that stuff. That's incredible. Growing up, my family was really not the outdoorsy type, and I want to change that. I want to be the dad that takes his kids out and do all the
Yeah.
stuff that your dad does with you. And I think that's such an important part of developing a person. But yeah, I would love to do that.
I think about with like my family, like, what's cool is that you get to start kind of once you start a family, you get to start traditions and you get to kind of stuff that
Yeah,
you have found interesting or cool. You can just get your kids into it and then you can do it
for sure.
do it with them.
Well, you
For
know what we
sure.
should do? We should do like a half Ironman together. We'll start training, pick a
Oh my
destination for
gosh.
it. Do you ride a
Yeah.
bike? Do you swim?
Yeah, I do all that, but
All
I'm
right.
definitely not as in shape as you. So I
Oh,
got to
well,
catch
Kevin
up to you.
Kevin runs and bikes already. I don't do as much as walk on the treadmill, but I could start back up. I just have to have a focus. Like if I know we're gonna do it, then I would do
He's
it.
better when he's got his goals.
Yeah, I gotta have a goal.
Like
Just
when we set the
in-
Yeah.
Kilimanjaro goal and set the other ones, and that's kind of what we like with social media too. Is like we were talking about it a little bit before we started recording, but yeah, we don't specifically do neurosurgery. We didn't start by making content for my dad. He didn't do that to get more patients or to get more people to do back surgery. It was more kind of sharing education, and then as we've seen stuff, cool way we raised like $23,000 for a couple of cool organizations when we did the Mount Kilimanjaro
That's
hike,
excellent.
and we got to do something. We did something cool. We both have been interested in climbing a mountain, and we talk about things. And COVID hit, I think, for a lot of people, and then it feels like there was a time vacuum a little bit. So
Yeah.
you just
Yeah.
kind of make. I think about it a lot. You just got to make yourself do stuff. Or you get so obviously you two much more than myself, but you get so busy with life, and then you realize you're not. It's cool to do some of these things and set challenges.
hmm
Yeah.
Yeah. I'm a huge fan of food too. So like if I ever have an opportunity to go try it's way out of my budget, but I really enjoy fine dining. So like Michelin star restaurants and stuff like that.
Wow.
I'm such a sucker for that type of propaganda. If a restaurant has a Michelin star, I'm very interested in going. So
Have you been to
that's one of
Nobu?
those.
Have you been to
Of
Nobu?
course, of course. Yeah, Nobu. I'm a huge fan of Nobu. I don't know
What
if
is it?
Nobu
What's
has any
that? What
Michelin
is it?
stars,
What
but
is that?
But it's
go
just
ahead.
a really popular restaurant. It's like Nobu in Malibu, and I think there's a Nobu somewhere else
That's
too.
right.
But just it's
Yeah,
like a
it's like
big thing people go to in like LA and
yeah.
around there. I think, right?
Exactly. That's exactly right. Yeah. So it does, interestingly, it does not have a Michelin restaurant. I could be wrong, but I'm fairly positive it doesn't have a Michelin star. I feel like it should, but it's
Yeah,
such an incredible place. It's the one that I went to here in LA is was actually in Malibu. So technically, I guess not LA, but I went to Malibu and it's right on the water and it's got like it's a whole experience.
yeah,
And when they seat you, the presentation of the food, the whole thing, I just am such a I enjoy experiences. And
yeah.
so stuff
You
like
like the
that, I think
experience.
yeah, I would absolutely pay top dollar for that, even if I don't get paid top dollar. So I really enjoy, because those memories stick with me. Some of the best
Yeah,
memories I have are over meals with family and friends, and it's
Yeah,
great
well,
to me.
that's
I really
awesome.
enjoy that. Yeah.
that's all. Yeah, that
So
is.
if you guys
Well,
are ever in the area, that's going to be where we go.
we will.
Excellent.
um,
I'll have to start looking those up right now. Shit, Kevin.
Oh man, it's great.
Find out the Michelin's thing.
yeah,
Oh, the Michelin restaurants are
We
game
drove
changers.
we drove by Malibu, didn't we, Kevin, when we were in Los LA? Didn't we
yeah,
drive by Malibu? Or we
yeah.
stopped at some surf
I
shop
don't
and got
remember
some shirts?
the
Or,
restaurant we went to, but it was very good. LA's
yeah,
got a lot of great food places
yeah.
in
It
general.
does. I would say the best food places that I've been to is Chicago for sure.
Yeah,
So
they've got great food.
Michelin stars, it's incredible. So the Michelin star system is based on one, two, or three Michelin stars. One Michelin star is really it's hands down like a game changer if you get one Michelin star. One Michelin star is in itself a huge achievement. Getting
Yeah,
two Michelin stars is even harder.
Oh,
And then a three Michelin star, there is only a handful in the entire world that have three Michelin stars. There's one in Chicago that we have that I went to, and it was incredibly overpriced, but the food is such an incredible experience that I've never had in my entire life. And so the
wow.
way that they take you in the kitchen, they show you how everything is made, and there's like a tour with it, and they pair the drinks with the food, and I could talk about this for hours, and I just really, really enjoy the way that, like, the science of food, and in a
yeah,
way, there's a lot of similarities to an operating room. There's like a head chef, and then they have the people working under their guidance and stuff like that. Then in a way, it's like an attending with the residents, and then there's a scrub tech that's like helping prepare the equipment and all that stuff. It's very, very regimented, and it's also like very hierarchical, just like the OR. If you have an attending, they're in charge, then there's a resident who's in charge of the medical student, and it's like all these things. It's I draw a lot of similarities. Yeah.
Do they have like a grand sommelier then at these places like Michelin?
Yes.
Yes.
Yes, absolutely.
Wow.
These places that are Michelin stars, oh, they will have the guy show up, and then he'll give you the full history. You can try the wine, the pairing. I personally don't drink alcohol, but you could do the whole thing. I mean, like they will. It's honestly an experience that when I went to this three Michelin star restaurant, I went before I left Chicago when I graduated residency. I've wanted to go to this place for as long as I could remember, and I could never, ever, ever get a reservation to this place.
yeah. It's probably very
Finally,
hard.
I was able, incredibly difficult. So I was able to finally meet somebody that I knew that actually was good friends with the person who's in charge of the reservations. And I told that person, I was like, "You got to get me a reservation." So right before I left Chicago for my residency, when I was graduating, I went to Chicago. I'm sorry, I went to this three Michelin star restaurant. It was called Alinea. And it was something I'll never forget. The
Wow.
interesting thing is the chef has had tongue cancer, and he
Wow.
actually had uh, uh, a significant portion of his tongue removed.
Removed.
Yeah,
And so he's a chef missing a significant portion of his tongue, which is incredibly sad, but also adds
Yeah.
to the elegance of the actual practice because he's so in
yeah.
touch with everything else, and he knows how to make such perfectly crafted food with limited taste. It's
Taste, yeah.
That's
incredible.
fascinating.
Yeah.
Yeah.
No, that
So,
definitely on the bucket list to get. I've never been to a 3-star Michelin restaurant. I think I've been to a
oh
1-star
man.
before, but yeah, no, it is. There is something about just meals with friends. There's something about really good experiences around food that are definitely a lot of fun.
Yeah,
So
agreed.
we really appreciate you coming
Yeah.
on, and for anyone who's watching, you can follow Dr. Z. It's Dr. Z Neurosurgery on TikTok and Instagram
It
and
is.
anywhere else on social media. And my dad and there, we're going to have to do a collab with you soon. We'll have
Would love
come
to.
up with, we got to come up with something to do together. That'd be fun. So thank you
Absolutely.
again.
To be able to work with one of the originals, it would be an honor. So yes, thank you for having me.
All right. Have a great day.
Yeah.
All right, guys. Take care.